Good afternoon and welcome. My name is Tim Poe. I'm Director of Telehealth with the UNC Cancer Network. Thank you so much for being here today, December 11th, 2019, for our last RN and Allied Health Lecture of the year. And I should mention, this is our last RN and Allied Health Lecture period. But that's not a bad thing because the series is being changed. It will have a new name, Patient-Centered Care. We're excited about this. You can find out about this in our newsletter, which was just sent out recently, or on our website, unccn.org. So basically, the audience for this series will stay the same, and in many ways it will be the same. But there are some changes, and it will have a new name. So if you don't see RN and Allied Health, look for Patient-Centered Care. That's what this series will be called moving forward. If you have any questions, if something's not working properly, please call us 919-445-1000 right away. You can also reach us at unccn@unc.edu. So let us know, and we'll do everything we can to help you as the lecture's just starting. Let's see. We will be using Poll Everywhere today. You may join by the web. That's one of the easiest ways to join. Just go to pollev.com, enter the letters UNCCN for UNC Cancer Network, so UNCCN, and then you'll be able to see the questions come up. In fact, that first question, our poll entry question, is already there. You can also join by text, by texting the letters UNCCN to the number 22333. You'll get a message back that says you've joined, and then you can respond there. Finally, there is a Poll Everywhere app that's available for Android and for Apple iOS, so feel free to download that. I've been using that more, and that works very well. Just put in the letters UNCCN. All right. Reminder that we have all sorts of free credits for this presentation, free CME, for some of ours, free CME, and then we have free ACPE and ASRT. We have live lectures, we have self-paced lectures, we have our media site library and our YouTube channel, and lots of places you can find out about all of our various lectures. All right. So this is going to be our first question. Nutrition is not very important for aging cancer patients. This should be a pretty easy one to figure out. You can let us know true or false on that. And without further ado, I would like to introduce our guest, Melissa Walter. Thanks so much for being here.
Thanks for having me.
All right, so let's see. We know a little bit about you here. According to my notes, you're a dietitian employed by the University of North Carolina's Department of Nutrition.
I am.
And you teach oncology nutrition to residential online Master of Public Health and Nutrition students, and spend your spare time on local farms and in your garden.
Yes.
Great. And you support patients in finding healthy ways to enjoy their favorite foods and embrace food traditions. Great. And what did I leave off? What's something we should know about you that wasn't on my list there?
You might be interested in knowing how I came to this profession.
Absolutely.
Nutrition is not my first career, but I came to this through personal interest. I was dealing with my own food challenges and food intolerances. But subsequent to that, my husband suffered a subdural hematoma. And so I learned at that time a lot more about nutrition and the brain and how nutrients impact our brains. And a couple of years after that, I became a cancer caregiver and took care of my best friend for several years until he passed away. And so I learned a lot about cancer nutrition through that. And so over the course of my career, I've been very interested in looking at the intersection between those.
Well, thank you so much. That's good to better understand that. And we are so excited to have you here today. Let's take a look at that poll question and see how folks are doing. So far, we're saying nutrition is not very important for aging cancer patients. So in general, we did get it true, but I think we're leaning towards saying false, that in fact nutrition is very important for aging cancer patients.
Yes.
is where I'm guessing we're going with
is.
that. Okay, good. So I'm going to go ahead and pass the controls over to you. And
Thank you.
We'll let you go ahead and get started. Thank you again.
Wonderful. So today we're talking about nutrition and our aging brains in cancer care. And we'll talk a little bit about how our brains naturally change as we age. We see that these alterations, though, become more complicated and often accelerated when we combine those with cancer treatments. And so at the end of this lecture, participants should be able to describe brain and neurological changes that are occurring as a result of chemotherapy and radiation treatments, to identify critical elements of a diet that provides support for age-related changes in brain function and cognition, and to discuss ways to provide basic nutrition support and to make referrals to dietitians when necessary to help lessen cognitive and neurological impacts of chemotherapy and radiation. I'd like to start out talking about what cognition actually is before we spend the next hour talking about it. So when we talk about brain changes as they relate to or are recognizable by our patients, we're really talking about changes in cognition. So we're talking about changes in intellectual development, in learning, attention, memory, language, reasoning, all of the things that you see listed here. And there are several risk factors for cognitive decline. And this can be cognitive decline as a result of cancer and its treatment. Particularly, we think about chemobrain, which is another name for chemotherapy-related cognitive impairment. It's a term that's common in cancer care. You probably have heard that. In fact, I did a Google search for chemobrain, and I got 21.2 million results. So people are talking about this, people are concerned about this. And when we look at this list of potential reasons or risk factors for cognitive decline in cancer care, we find that it's nearly identical to the list of risk factors for age-related cognitive impairment. And the list includes things you see here like hormonal changes, oxidative stress, inflammation, shortened telomeres, and we'll talk about what some of these things mean, genetics, sleep disorders, fatigue, depression, anxiety, and stress, pain, altered gut integrity, low cognitive reserve, and of course, last but not least, nutritional deficiencies. So you can see that for cancer and age-related disease, these lists are identical other than the fact that we do see direct treatment toxicity from cancer treatments. So on the prior slide, one of the risk factors noted on both lists was low cognitive reserve. And this term refers to our brain's resilience in the face of structural or functional changes due to cancer, cancer care, aging, or other diseases. So brain reserve is a passive model of reserve. It's related to our brain size, our brain structure, architecture. And this model really suggests that there is maybe little that we can do to alter cognitive reserve because we don't have much control over the size of our brains. So no lifestyle factors would help us with this. So in this quantitative model, we theorize that the larger the brain is, the more harm our brain can withstand before we start to see clinical symptoms. And this idea is supported by studies that suggest that the prevalence or the incidence of dementia is lower in individuals who have larger brains. Cognitive reserve, however, is a more active model of reserve. It suggests that it's the quality of our brain function rather than the quantity of our brain matter that's providing us with this cognitive reserve. And this model suggests that people who have higher cognitive reserve use compensatory approaches to cognition to better cope with damage to the brain. So under this model, we could see that the same amount of brain damage would have different effects on different people, even if the brain size is held constant. And some studies have shown that even at the same chronological age and with the same number of illnesses, older patients vary from having high reserve, so we think about them being biologically younger than their age, to being frail or biologically older than their age. And cognitive reserve can be improved by things like life experiences, mentally enriching activities, education, occupation, socioeconomic status, physical exercise, and nutrition, which I didn't put on this list, but we will be talking about. So this is a more graphic representation of this concept. So cancer treatment can cause an identical change in brain resources. However, the impact on cognitive performance will be less at a younger age, and then it increases as we get older. In addition, the impact on cognitive performance is going to be less in a person with high cognitive reserve and greater in a person that has low cognitive reserve. We know that cancer treatments can have a direct effect on cognition, but we don't often think about their interaction with various risk factors. I hope you can see this okay on your slides, and not too small here, but the factors on the left represent non-modifiable factors. So things like age, things like tumor type or tumor stage, things like our genes. However, the factors on the right are modifiable or treatable predisposing risk factors. So we have impact over our lifestyle choices, over our health, over our mental health. And if we look at this same graphic and remove all the references to cancer, then we see a list of risk factors that are common just to aging and cognitive function.
All right, so we have our first poll question after our introduction there. So which is more important as a risk for cognitive decline, whether from cancer or aging? And A is brain reserve and B is cognitive reserve. Some of you may have already answered. If not, go ahead. This is all anonymous. You've got nothing to lose. Go ahead and take your best shot at this. So far, we're really trending with cognitive reserve. We'll wait about 10, 15 seconds. Let some more folks answer that.
Absolutely.
Melissa, how are they doing?
I think it's looking good.
Good, good.
I like the trend.
Okay, great, great. Thank you so much. Just a reminder to our audience, by the way, I'll mention at the end of our last multiple choice question that we'll open up the poll for questions that you have. So be thinking about questions that you would like to ask Melissa. We'll open up time for you to submit those questions at the end, and I'll let you know when the poll is open for those.
Great.
All right. You can go here. We'll go ahead and
All
advance.
right. All right, so again, trend looked good. You are correct. Cognitive reserve is the best answer here. So while there is evidence, I mentioned to you that, that a larger brain may offer risk reduction for Alzheimer's or other dementias, there's greater evidence supporting the idea that cognitive reserve, or our brain's ability to compensate for changes resulting from damage, offers us more protection from cognitive decline. So going back to the earlier slide we looked at related to risk factors for cognitive decline, we have both knowledge of basic nutritional biochemistry and significant evidence to suggest that supportive nutrition can mitigate each of these risk factors. So while there's greater research on this related to nutrition's impact on aging and chronic disease than there is on nutrition's impact on cancer-related cognitive change, there's no reason that we shouldn't or wouldn't believe that by mitigating these risk factors in general, we can't also decrease risk for cognitive decline in cancer and treatment. And we'll spend the rest of our time today really talking about how nutrition relates to each of these topics, starting at the top of the list with oxidative stress. So oxidative stress it's an imbalance between free radicals, which our bodies make during normal metabolic processes, and antioxidants in our bodies. Antioxidants, we'll get a little technical here now. Antioxidants are molecules that donate an electron to an unstable free radical without making themselves unstable. And this causes the free radical to stabilize and become less reactive. And several factors contribute to oxidative stress and to excess free radical production in our bodies. And these factors can include things like diet, lifestyle, particularly related to exercise, smoking, and drinking, medical conditions, immune response, and environmental factors like air pollution, radiation, and chemicals in our environment. And we know that when oxidative stress occurs, it acts at an epigenetic level, so it's altering gene expression, but it also acts as, it also activates inflammatory pathways. And in both of these ways, oxidative stress is contributing to both diseases of aging and to changes in cognition. However, there's significant evidence that diets high in antioxidants, which are found in the greatest quantities in fruits and vegetables, can be protective against oxidative stress and cognitive decline. And I do have patients ask me about antioxidants and if these antioxidants are impacting the effectiveness of their cancer treatments, particularly of chemotherapy. And so I looked at a 2007 literature review that does indicate that these foods or supplements, and particularly foods, tend to enhance effectiveness of treatments, to decrease treatment side effects, to help protect our normal tissues, and they may actually increase survival. I mentioned oxidative stress as one cause of inflammation. However, in both cancer and aging, there are a lot of causes of inflammation. This triangle, composed of nutrition, inflammation and immunity, and cancer, indicates that poor nutrition quality and inappropriate quantity predispose us over time or with age, either dependent on or independent of our immune system, to more deterioration in function that may result in cancer development or cancer progression. We know that inflammation is part of our immune system's response to defend our body against infection, so it's important, but it does also affect our brain and our cognition. Nutrition can have a direct impact upon these, I'm having trouble here, upon inflammatory processes in both aging and cancer. So an anti-inflammatory diet would include a lot of fruits and vegetables. Generally, we recommend 4 to 5 daily servings of fruits and vegetables so that we get those antioxidants. We get vitamins, minerals, fibers, all of these things that help to lower levels of inflammatory markers. We also know that whole grain foods do the same thing. And then we recommend decreased caloric intake or weight loss to also help lower levels of inflammatory markers. However, I do want to note that this is not something that we recommend during cancer treatment. We don't want to see weight loss during treatment, but this is something that can be very helpful as a preventive measure and can be very helpful to prevent recurrence in survivorship. Nutrition and telomere length. So nutrition can impact the length of telomeres as well, and telomeres are little protective caps on the end of our chromosomes, and these protect our chromosomes from deteriorating or from fusing with other chromosomes. And telomere length actually is normally decreased in aging, and it's normally decreased with cancer and with cancer treatments. However, we have seen evidence that telomere length can be increased with dietary changes. Particularly, there's been research on the Mediterranean diet, the DASH diet, which is dietary approaches to stop hypertension, and these 2 USDA diets. And we'll talk a little bit more about some of these diets, particularly Mediterranean and DASH, but I just want to note these are diets that are very heavy in whole grains, fruits, and vegetables. You maybe are seeing a little trend here. We also know that nutrition can impact our genes. So nutrigenomics is simply, it's the concept of epigenetics as it relates to nutrition. So it's looking at how various foods and nutrients influence the expression of our genes. In simple terms, people can have a multitude of genes that predispose us to various health conditions or various health risks. However, it often takes some sort of triggering event or triggering influence to activate those genes. And we've learned that there are a lot of foods or nutrients that can act to reduce risk of harmful gene expression. One example of this is broccoli. So broccoli contains a bioactive component called isothiocyanates, you can see on the list here. And these isothiocyanates influence activation of p53 tumor suppressor genes to help reduce our cancer risk. And there are a lot of fruits and vegetables, again, that contain nutrients that are influencing the activation of genes that contribute to cognitive decline as well as cancer. Nutrition also impacts sleep. We don't think about this often, but there's evidence that lack of sleep results in somatic impairment. So we see impairments to immunity and increased disease risk. It impacts our emotional impairment, so negative feelings and behaviors, our cognitive impairment, so again, memory, attention, problem solving, and it also increases the rate of cognitive decline. And we've learned over more recent years about something called the glymphatic system. And the glymphatic system is like a lymphatic system for our brain. It's named for glial cells in our brain, and they help to remove wastes from the brain. This is a system that's active at night and helps to clean toxins from our brain each night. And if the system is impaired by age, brain injury, cancer treatments, those sorts of things, this may allow amyloid beta and tau proteins to accumulate. And these are these are hallmarks of Alzheimer's disease and other dementias. So we see sleep disorders being tied to age, to Alzheimer's, to other neurodegenerative diseases and brain injuries, even to some cancer treatments. And we still don't know really which comes first. We don't know which is the chicken and which is the egg, but we do know that it's very important to address these sleep issues. So from a nutrition perspective, weight loss, again, can help. And again, I will say this is more in prevention. This is more in survivorship. But even 5 or 10 pounds overweight can lead to sleep apnea by comprising respiratory function. And then we create this vicious cycle where apnea creates greater fatigue, and greater fatigue can lower our motivation to eat right and to exercise, which can ultimately result in increased weight and decreased cognition. Nutrition also can help through the avoidance of spicy foods, chocolate, fatty foods, things that might trigger reflux or heartburn, because this impacts our sleep quality. Eating larger meals earlier in the day, like breakfast and lunch, and then having lighter meals for dinner can be helpful. Also avoiding evening snacks. And this helps from the perspective of reflux and heartburn, but it also seems to help with quality of sleep. And finally, we recommend to patients that they avoid low fiber diets and that they avoid high fat and high sugar diets, as these are also associated with lighter and less restorative sleep, and also with more arousal through the night. So you'd be waking up more often. There have been numerous studies that have found correlations between nutrition and mental health. We see that nutrient deficient diets, particularly low carb diets, can increase depression. We've also seen correlations between improved diet and improved mental health. So we see a link between high fish consumption, or higher omega-3 fatty acid consumption in particular, and lower incidence of mental illness. We also see that supplements and foods that contain amino acids, which are protein-rich foods, are helpful because we use those amino acids to make neurotransmitters, things like serotonin and dopamine, our feel-good neurotransmitters. And then a variety of nutrients like folate, B12, iron, these listed here, all found in fruits and vegetables, can also help to reduce mental health symptoms. So to give you a little bit more detail on that, let's look at tryptophan as an example. Tryptophan is an amino acid we get in our diet, and our body uses that to make serotonin, which is one of our feel-good neurotransmitters. Unfortunately, enzymes that are influenced by inflammation and by aging can break down tryptophan before it can be converted to serotonin. We also see chemotherapy impacting serotonin levels. So while high tryptophan foods won't directly boost serotonin on their own, because tryptophan is competing with other amino acids for entry into the brain. We can eat tryptophan-rich foods with high carbohydrate foods, like eating turkey and mashed potatoes at Thanksgiving. And these carbohydrates will cause our body to release more insulin, and this is promoting greater amino acid absorption, but leaving more of the tryptophan in the blood. So some higher tryptophan foods that might be helpful include eggs, cheese, tofu, turkey, nuts, and salmon. And speaking of salmon, there is evidence that omega-3 fatty acids, which we find in salmon and many cold water fish, help to reduce inflammation in the body, which can also improve our mood. So probably many of you have heard about a study that came out, I believe, in 2018. And this study indicated that there may not be any risk reduction for cardiovascular disease with omega-3 fatty acids, or particularly fatty acid supplementation. But we haven't seen that same evidence related to omega-3 fatty acids and inflammation and many other diseases. So I still recommend this. I think it's very helpful. And great food sources for low mercury omega-3s are what we call smash fish: salmon, mackerel, anchovies, sardines, and herring. Nutrition, as you might guess, also has a big impact on gut health. So our gut and our brain become linked during embryonic neural development. And this link occurs by way of the vagus nerve. So if you look at my little cartoon here, the vagus nerve would be the telephone line that's connecting the brain to the gut here. And this connection is strengthened after birth when our bodies start to develop colonies of bacteria in our gut and elsewhere in our bodies. And these bacteria are known as our microbiota. Unfortunately, both aging and chemotherapy alter our bacteria and often destroy our bacteria. And I'm going to go back to this slide for just a moment and talk about why that's important. So what do we really lose when we're losing bacterial diversity or quantity? Well, one of the things that bacteria does for us is that it helps with nutrient extraction from food. So for example, when we eat insoluble fiber, and you think about thick or tough cell walls on plant material that we're eating, our fruits and vegetables, that would be insoluble fiber. And the bacteria in our guts digest that, whereas we can't on our own. And when they digest that, they're breaking that down into short-chain fatty acids. And we use those short-chain fatty acids for a significant amount of energy in our bodies. And one of those short-chain fatty acids is called butyrate. And butyrate helps to decrease depression and anxiety. It also helps to activate that vagus nerve, so helping with our gut health. We also need bacteria for vitamin production. We don't have the ability to make vitamin K or B12 without that bacteria. Bacteria helps to regulate inflammation. It helps with drug detoxification, which is really critical during chemotherapy. It helps to provide 70% of our immunity and provide us with defense against infections. Bacteria actually helps to regulate angiogenesis or blood vessel formation, and we know in cancer care that's critical. And finally, bacteria help with behavioral support because they help to provide support for neurotransmitters. We make neurotransmitters, we secrete them in our gut just like we do in our brain. And these neurotransmitters help to alleviate symptoms of depression, anxiety, even to help with behavioral symptoms related to autism. But these don't cross the blood-brain barrier. They're actually sending signals by way of the vagus nerve. So how do we support those bacteria? Again, we eat more plants. And particularly here, eating pre- and probiotic foods can be helpful. So prebiotic foods are foods that feed the bacteria in our guts and in our bodies in general. And we have bacteria everywhere in our bodies. So we need to feed all of these. And these include, again, these fibrous vegetables, fruits, these insoluble fibers. They include garlic, onions, oats, and beans. And then probiotic foods are foods that actually contain live bacteria. So these are our fermented foods like sauerkraut and kimchi, kombucha, pickled vegetables, yogurts, kefir, those types of things. So eating a good combination of both of those is very helpful. It's also helpful when possible to avoid taking antibiotics and non-steroidal anti-inflammatories and to avoid artificial sweeteners. We do see evidence that all of these can help to destroy bacteria in our bodies. It's very important to limit the use of hand sanitizers and antimicrobial soaps. And this is a hard one because we think about wanting to remove bacteria, to have clean hands before we eat a meal. But what we're finding now is that people do that, and there's research to indicate that after we do that and then we eat our food, when we touch our food, we're actually getting that hand sanitizer or the antimicrobial soap on the food and then ingesting it, taking that into our bodies and killing more of the bacteria in our bodies. So it's just fine to use just plain old soap and water to wash well before you eat. And then finally, there's evidence to suggest that getting more fresh air, so keeping your windows open in the house or getting outdoors more, can help with bacterial diversity. So can getting dirty. We see that people who garden or work in their yards quite a bit have greater diversity. They're probably picking up different types of microbes from the soil, from the environment, and this is helpful for our bodies. And finally, my favorite, because I'm a dog lover, we do see that people who have dogs tend to have greater microbial diversity, and it probably goes right back to maybe getting fresh air walking our dogs and getting dirty because our dogs are bringing dirt in, but it's a good argument for having a dog. So now we're going to talk a little bit about some specific diets. We've talked about various ways that nutrition can improve those specific risk factors for cognitive decline, but I want to leave you with some resources that you can use at home or that you can share with your patients regarding a supportive diet. And I want to mention a few dietary challenges that are specific to people with cancer. And so we'll start here by looking at the American Institute for Cancer Research's New American Plate. So they've developed a plate for people to use, indicating that we should be eating 2/3 or more of fruits and vegetables, whole grains, and beans on our plate. And 1/3 or less of our plate should consist of animal proteins. So this is a really easy thing for nurses, for physicians to talk with patients about, or to give them a graphic or point them to the website and say, here's a very simple way to think about eating. It doesn't have to be complicated. Another thing that as dietitians we talk about with our patients is superfoods. We have people come to us so frequently talking about acai berries or other foods that are considered superfoods to help fight cancer or to help with symptoms that we're experiencing. But we always tell our patients that we need a combination of a lot of fruits and vegetables and whole grains to get all of the nutrients that we need for antioxidants and for that nutrigenetic support that we talked about. We also like to tell our patients that we believe that whole foods are much more effective than supplements, and that actually supplementation of some compounds appear to be cancer causing, or there's some evidence for that in some settings, while the food sources can be cancer fighting. So again, we really encourage our patients to eat a wide variety of foods and to eat whole foods. The diet that I work with the most with my patients is the MIND diet. And the MIND diet is the Mediterranean Intervention for Neurodegenerative Delay. And so I mentioned we were going to talk about the Mediterranean and the DASH diets again. I'm not going to go into detail about either of those diets other than to say that this MIND diet is a diet that was developed from both of those, taking components that we had specific evidence for related to cognitive health. So the MIND diet is an anti-inflammatory diet. It's very flexible, so we don't tell patients about any calorie limits. We don't eliminate any food groups. This is a diet that's combining all of those plant fibers, antioxidants, omega-3s, lean proteins, all of the things that we just suggested were important for cognitive health. It includes all of the important macronutrients, the important micronutrients. It helps to reduce added sugars, saturated and trans fats. And we see that when people follow this diet with moderate adherence, we see about 35% risk reduction in Alzheimer's disease, which is pretty dramatic. And then people who follow this diet more strictly see up to 53% risk reduction. So it's a very powerful diet. And yet, if you look down, you can also see that it's a really simple diet. And I put these little orange dotted lines around here as a little tip for you. You can cut this out. You can put this on a note card. This is something that you can easily in the clinic give your patients to give them a guideline to follow at home. It's very simple. So the MIND diet, of course, is all about eating more plants, as you've already heard today. But the MIND diet recommends that daily people eat 3 servings of whole grains. So what does that look like? That could be oatmeal for breakfast. It could be a piece of bread or some crackers at lunch. It could be brown rice or any other whole grain for dinner. The diet also suggests 1 serving of leafy greens each day, plus 1 other vegetable each day. And this is really doable for a lot of people. It's really hard when people see a diet that recommends that they eat 4 or 5 or 10 servings of vegetables a day. It's intimidating and people just back away from that right away. But when you say, I want you to eat 2 vegetables a day, that's something that people feel like they can do. The MIND diet also suggests that if someone drinks, that 1 glass of wine, red or white, can be beneficial to brain health, and it recommends cooking with olive oil daily. The MIND diet includes snacks of nuts each day, so just a small handful of nuts can be helpful. Every other day, including some beans, about 1/2 cup of beans, and it can be more than this, so if somebody wants to eat beans every day, that's great. At least twice a week, eating poultry, and 1/2 cup of berries. At least once a week, eating fish, and it's helpful if that is a cold water fish that's higher in omega-3 fatty acids. And then getting exercise. And in terms of limitations, this isn't a diet that says you have to cut out all of these things. It's actually pretty good because it limits red meat, but to fewer than 4 servings a week. And for many of us, that actually feels like a lot. It limits butter and margarine to a tablespoon or less each day, and cheese to a serving or less each week. I think I find the cheese the most challenging, but the reasons for limiting these things is saturated fat. The diet limits sweets to fewer than 5 servings a week, so you can still have dessert during the week. And it limits fried or fast foods, ideally to no more than 1 serving a week. So here, looking at a comparison between these two, you can see that the 2 diets are very similar. The MIND diet gives us a little more detail about how to eat, but it is very much in alignment with the American Institute for Cancer Research's New American Plate. When we're recommending these diets to our patients, or if we're patients, when we're thinking about these diets, we know that there are a lot of nutrition risks with cancer treatment, but people are often very motivated to make dietary changes throughout treatment because it's one area of our lives that we can control directly. Unfortunately, we know that side effects can make these dietary changes challenging. So looking at the list here, we know how common psychological distress or emotional distress can be, and that can impact our appetites or our ability to eat. We see that pain is common, fatigue is incredibly common, anorexia or loss of appetite. We see alimentary or GI tract disturbances from the mouth all the way down, and of course that's going to impact eating. We see malnutrition, which can include not just calorie or caloric insufficiency, but also protein deficiencies, vitamin and mineral deficiencies, and even dehydration. We see weight loss and weight gain being a problem. Weight gain typically more related to medication side effects. We see sarcopenia or muscle loss, and we see cancer cachexia. And we know that weight loss throughout treatment, of course, leads to greater treatment side effects, which in turn can often lead to missed treatments and poor response and prognosis. So as practitioners, it's very important for us when we're recommending diets or nutritional changes to our patients to be considerate of all of these and to help our patients deal with these as they're also trying to maintain a healthy diet. So in addition to the previous slide with side effects from cancer treatment, we see a host of symptoms that are related to both aging and cancer. So we may see things like visual changes, loss of taste buds or olfactory buds that impact taste and smell, less saliva production, tooth decay. We see often decreased tactile sense. Patients may experience peripheral neuropathy, either with aging or with cancer treatment. And that can impact self-feeding, the ability to hold silverware, for example. We see declines in muscle or motor function, weakness, lower appetite, altered absorption and metabolism. And then we see things like depression, loneliness, irritability, loss of memory, all of these things that we relate to cognitive changes. And it can be very hard to tease out whether these are changes related to aging or changes related to the cancer or cancer treatments. And now I'm going to throw a monkey wrench into that and say that those also may be changes related specifically to malnutrition. So looking at this list here, I always like to suggest that it's important to get a diet history from our patients and to consider potential blood work to test for nutrient deficiencies, because all of the symptoms from the previous page, all of these symptoms that you see here listed can be directly attributed to malnutrition, which is simply inadequate calories, inadequate micro or macronutrients, or inadequate fluid. So you can see here all of these side effects of various nutrient deficiencies that mimic chemo brain, cognitive decline, or other cancer treatment symptoms.
All right, and here we are with our next Poll Everywhere question. Your 78-year-old breast cancer patient has developed peripheral neuropathy. Is this most likely due to A, normal aging, B, her chemotherapy, paraplatin, carboplatin, C, malnutrition, or D, I don't know without testing her vitamin B12 levels? All right, so for those of you who've already responded, I'll open that up, and then for those of you who have not yet responded, we encourage everyone to go ahead. Again, it's anonymous. What do you think would be the correct answer? And I'm glad to see a lot of different answers here. We'll take about 10 more seconds to give you a chance to respond to this question.
This is the time I would love to be interacting with my audience and to find out who's answering in what way, because I think that's very different. We may have a very different response depending on how we work with patients or whether we are patients.
Absolutely, yeah. If we had more time, we'd be able to do some follow-up on this. How are they doing? And do you want to go ahead and advance to the next slide and let them know that the answer that you were looking for?
Let's do it.
And then we had a lot of folks responding to both B and D, so maybe we can help figure out why one or the other was so popular.
Absolutely, and I'm not surprised by that answer at all. So any of these can cause peripheral neuropathy.
Okay.
And I've noted here, it might be a practitioner's first instinct to think that this is a side effect of chemotherapy, but it's important for us to find out if this is actually a B12 deficiency due to poor diet or due to aging. So in normal aging, it's really common that we make less intrinsic factor in our stomach, which is required for B12 absorption. And in both cancer and aging, there are a lot of factors that lead to lesser intake. We just talked about that, into micronutrient deficiencies. So it's really critical that we look for and address the root cause of this problem rather than making an assumption that this is related to chemotherapy.
Great.
Because if it is a micronutrient deficiency, that can cause permanent nerve damage that we could help to avoid.
Absolutely. Well, that's important, and thank you, and thanks to our audience for responding to that.
All right. So before I leave the topic of malnutrition, I want to quickly address the misconception that we can look at a person to know whether he or she is malnourished. So again, the definition of malnutrition was simply a lack of proper nutrition. And I said that can be inadequate calories, but it can also be inadequate macronutrients, micronutrients, or water. It can also be overnutrition. So it's common in developed countries like the United States to see overweight people who are malnourished, as we would see in the image here to the right. These people may take in enough calories, or maybe too many calories, but these may be from eating a lot of these burgers, a lot of meat, a lot of fried foods, a lot of sweets, a lot of carbohydrates, a lot of foods that may be less expensive than fresh fruits and vegetables. So even if our patients or we are getting enough calories, it may still be a diet that's inadequate in vitamins and minerals. Now this is a list of common nutrient deficiencies in aging, along with foods that can help us to increase those nutrients in our diet. And I'm not going to go through all of these, but I wanted to leave you with this as a resource at home or a resource that you can share with your patients. And I also wanted to one more time stress the importance of hydration. As we get older, we lose our ability to sense thirst. We also see that patients commonly drink less with chemotherapy related to side effects of chemotherapy. And dehydration is a leading cause for admissions to ERs and hospitals for older adults. And what's happening as we take in less fluid, our cells are actually shrinking. And this can lead to those symptoms of poor cognition, short-term memory loss, alterations in our ability to work with numbers or psychomotor function, attention, those types of things, increases in confusion and disorientation, negative impacts on mood, and also headaches. So I particularly work with a lot of older adults, and this is one of the first things that we look at, and we try to determine how much water or how much fluid a patient is taking in each day, because we see really significant differences when we help patients just to know how much fluid they need to be taking in and help them find ways to do this.
All right, and our final poll everywhere question: is there any point in suggesting that my patient start the MIND diet or a similar diet if he or she is already experiencing cognitive decline? And our answers: A would be absolutely, B would be only if I test him or her and find a nutrient deficiency, C only if a diet history, only if I take a diet history and determine that he or she isn't eating a balanced diet, and D, no, it's too late once cognitive changes are occurring. So we'll go ahead and open that up so we can see the responses that we have already. Looks like we're trending in one direction, and also have some folks thinking that that third answer might be correct. So for our audience, thank you again for responding, and take about 5 more seconds, if you would, to go ahead and put in your response if you haven't already. All right.
And I don't want to sway those responses, but I am going to say I'm really excited to see the enthusiasm about making a change in diet.
Good, good.
So we'll look at that. And yes, the answer is absolutely. There's definitely a point in making those recommendations to our patients. So looking at diet history, That's very important. Nutrient testing can be very important. It can be very helpful in guiding dietary changes, even in supplementing, so we can determine if our patients are low in particular nutrients and try to help them with supplementation or help them with dietary changes that way. But it's never too late to make a difference, and there's evidence to suggest that we actually can see changes in cognition with dietary changes, even starting partway through treatment or as we're aging.
Great to know. Great to know. And before we move on to the next slide, just to let the audience know that we have opened up Poll Everywhere for questions now. So right on through the end of the talk today, you can go ahead and start submitting your questions to Melissa, and then we'll take those at the end.
Great, thank you. We'll wrap up here with just a couple more slides. So speaking specifically to practitioners, I want to note that interprofessional collaboration is really critical as we're looking at nutrition care for our patients. We know that nutrition-related side effects of cancer and cancer treatment can be really challenging for patients to manage. So can nutrition-related side effects of aging. But nurses and physicians are really nutrition's front line. You all see patients before we as dietitians do. So again, that collaboration is really important. Early and regular nutrition assessment and intervention and taking a more multidisciplinary approach to nutrition care has been shown to improve treatment tolerance for patients. And during the acute phase of curative oncology treatment, adequate nutrition support has been shown to improve short-term outcomes by reducing complications and by shortening the recovery phase. And finally, maintaining appropriate supportive nutrition can reduce the risk for cognitive decline and can sometimes reverse decline, as we just talked about, whether it be from cancer and treatment, from aging, or from both of those combined. And finally, I'd like to let you know how dietitians can help if you choose to bring a dietitian in to work with your patients. So registered dietitians can help both patients and practitioners in managing those nutrition-related side effects of treatments, including but not at all limited to cognitive changes. So we can make recommendations about foods and eating strategies, about meal plans and meal patterns that can complement medication management of those side effects. We can help to offer strategies to prepare healthy foods in more palatable ways or more tolerable ways as our patients are maybe experiencing mucositis or GI issues, things like that. We can help to accommodate those nutrition symptoms. We can aid in the management of multiple chronic side effects that are affecting eating and digestion and provide both psychological and nutritional support when oral intake is poor or when we anticipate that it's going to become poor. We help to monitor weight loss and muscle loss. We help to aid in prevention, identification, and treatment of malnutrition, which can be critical during cancer care. We can help with the management of tube feedings and formulas. We provide weight management and dietary guidance and survivorship as well. And then one of the things that I think can be the most important, we can answer those in-depth nutrition questions of patients but also of caregivers. So we're here for families. We're here for support of patients in a broader sense. And I wanted to include a link here for you so that if you wanted to talk to one of the oncology dietitians here at UNC, you can follow this link and reach out to them. I want to thank you so much for your time. I've got 3 slides of references here if you wanted to go back to any of that research. But again, thank you so much for being here.
All right. And Melissa, thank you. This has been fascinating. A lot of great information here. So we have a few minutes left. We're going to start taking questions in just a moment. So this is great. So I learned that when I woke up this morning and my dog Ruby had migrated to where her head was on my pillow, I was actually taking good care of my health.
There you go.
Yeah.
Good for those microbiota.
Yeah, absolutely. So let's see, we already have questions coming in. Again, if you haven't submitted a question yet, you can go ahead and do that. First one, how much does cooking veggies take away from the nutrients compared to fresh, we'll assume raw vegetables?
Yes. I'm sorry to tell you this, but that's a loaded question because that's different for most fruits and vegetables. For example, we know that cooking carrots can increase the nutrient value to us because we can better absorb that. But we know with some other fruits and vegetables that cooking can destroy some of those nutrients. There are a lot of websites out there to help you figure that out, but I really like to suggest to people that if you eat a wide variety, maybe you eat raw carrots for lunch and tomorrow you eat cooked carrots for dinner, and maybe some days you saute your kale and some days you chop it up raw in a salad. If we do a variety of those things, I think we're getting the greatest amount of nutrients that we can from our food and making that much simpler for ourselves.
Great, great. And I'll ask for clarification sort of leading from that. When we talk about fried foods, we're not talking about zucchini and broccoli and some onions fried in olive oil.
We are not. Let's call that sauteing.
Okay,
like
great, great. Okay,
we're talking about that breading and throwing it in a deep fat fryer and immersing it in oil, that sort of thing.
Great, gotcha.
Thank you for clarifying
Absolutely. No, thank you. Great presentation. Thank you so much. Thanks for all the references as well. And of course, this lecture will be in our learning portal. It will be in our library, and we'll have all of the slides available as well. So if somebody wants to go back and look at all of those references and click on any of those links, that's all available. Let's see, it looks like we've got another question here. Are you involved in any research regarding nutrition and cancer control?
I am not directly involved in that. However, I work in Gilling School of Global Public Health, and we have several groups in our department, our nutrition department over there, that do work on that. So if somebody has a specific question, I think my email address was in the very first slide here, and you are welcome to reach out to me, and I'd be happy to connect you with those groups.
Great, thank you so much. And I was thinking about, you had made some references to ChemoBrain earlier in the lecture, and just to let our audience know if they're interested in finding out more about ChemoBrain, we have several very good lectures on that.
Yes.
And feel free to go back. The most recent, I think, was Zev Nakamura, and we've had others. So feel free to go back and look at those. Let's see, another question here. If you have a motivated patient and family, is there evidence to show vegan or vegetarian diets offer a greater benefit? What about protein?
That also is a challenging question. There have been some studies that do indicate that particularly vegetarian diets can be perhaps more beneficial. I think more so related to cancer treatment than specifically to cognition. But you're right, we do have to have motivated patients and families because protein is very important, as you note here, and it can be very hard to do that in a vegan or vegetarian diet. We know that a lot of people eat beans, but there may be a lot of people who are not aware that when they eat those beans, they need to be combining that with rice, for example, at some point through the day. It doesn't have to be in the same meal, but otherwise we don't get all of the essential amino acids that we need from those beans. We need that combination to form a whole protein. So it does involve some research, potentially working with a dietitian to make that helpful. That's why I really like the MIND diet, and I really like the American Institute for Cancer Research diet. Both of those don't indicate that you have to eat a vegan or vegetarian diet, of course, but they are very heavy on the fruits and vegetables. So I think that provides the balance that we need and all of the nutrients as well.
Great. Let's take one more question. Excellent presentation and valuable information. However, concerning low carb, what study points to increased depression as a result of lowering carbs, especially simple carbs?
I apologize if I did not put that on the slide. I can't name that off the top of my head. Is there a good way for me to provide that or to give you an updated link on that as you post the slides?
We can do that as we post the slides. We'd be happy to, absolutely.
Perfect. Then check back here with us.
And you can also reach out to us at unccn@unc.edu with any questions. I'll close with one last one of my own. We've had some talks about personalized medicine. Do you see us making progress in the future towards personalized diet as it pertains to cancer treatment and cancer prevention?
I absolutely do. I kind of like to think that's the wave of the future. That's where we're headed in nutrition and medicine in general. And there's a lot of great research happening here at UNC.
Good.
So it's a good thing for people to follow here.
Great, great. Well, let's take a look at just a few things very quickly. We want to say thank yous. We want to thank the North Carolina General Assembly for their generous support of Lineberger, the Lineberger Comprehensive Cancer Center, the University Cancer Research Fund. Very appreciative. We're very appreciative to the team here, Mary King, Veneranda Obore, and John Powell for all the hard work they do to make each one of these lectures possible. We have one last medical and surgical oncology lecture, and just like RN and Allied Health is changing names, MedSurg is going to become Research to Practice starting in 2020. So our last lecture called Medical and Surgical Oncology, Updates in Radiation Oncology with Dr. Wang, and that's December 18th at noon. So we'll look forward to that. And then our next lecture, the first one of 2020, is the benefits of exercise for cancer patients with Gabriel Brennan, and that's a patient-centered care, or PCC as we're calling them, January 8th noon. So that said, we have self-paced courses, and we have always more courses coming online, clinical trial update in head and neck cancer and working with patients through interpreter services. And these, along with about 22 other lectures, anyone can go and take at any time, day or night, within about a year of the presentation. You know where to find us, 919-445-1000, and our website, unccn.org, for a wealth of information. As always, please reach out to us. Let us know your questions and comments. Melissa, thank you so much for being here. We really appreciate it. Thank you so much to our audience. We love you. We're glad to have you here always, and we look forward to seeing you next time. Thanks so much.
Thank you.